Today, Central Venous Pressure Measurement Basics, aka CVP. So we're going to talk about what CVP or central venous pressure is. We're going to talk about how to measure it, how not to. If I could just take a quick 60 seconds of your time, I wanted to introduce our newest whiteboard medicine emergency and critical care community, and that is our Patreon community. Here we post emergency and critical care medicine medical education topics every other day. We focus on landmark trials, new trials, clinical pearls, bedside tips and tricks, and much more. Everything emergency and critical care. We also upload study guides for each video. We have practice tests, and our newest addition is going to be mini courses that kind of lay out video study guides, practice questions into an easily digestible form that we hope is very applicable and helpful to the bedside. Our goal is to try to get even 1% of our YouTube community to join our Patreon community. It would be incredibly helpful in allowing us to spend more time creating content and elevating our current content. We appreciate you all, and we hope to see many of you there. The phlebostatic access, zeroing, what normal values are, what they mean, etc., etc. Quick shout out for those interested. Our Patreon page is linked in the video description. This is our Patreon page. If you have an interest and want to join, we post all the video outlines that you're able to download and follow along if you have an interest in that. Otherwise, no further ado, CVP. So first, starting with what CVP is. So CVP, aka central venous pressure, is just what it is describing. It's the central pressure of the venous system. So venous being veins, right? Central being close to heart, and pressure being pressure, right? So it's the pressure in the veins close to the heart. If this is a heart here, great illustration drawn by us. What we have, this is the right atrium, right ventricle. This is the tricuspid valve. Then this is the left atrium, left ventricle. This is the mitral valve. Okay. This is the pulmonary artery system going to the lungs. All right. And then this is the aortic arch up here. So this vessel here and this vessel here are what we're going to focus on, because this is the inferior vena cava, or the IVC, and this is the superior vena cava, or the SVC. And these are the two big veins that dump blood into the right side of the heart, or the right atrium. So these are kind of the central veins closest to the heart. This gets it from the upper body, right? So if we were to draw a little stick man over here, so we got a stick man, could be a stick woman too, and we have their heart. All right, so here's their heart here. And the top of the body, all the venous blood from the top of the body, the brain and everything, would dump into the superior vena cava and then go into the heart, whereas all the blood from the lower body, lower extremities, torso, and everything like that would dump into the inferior vena cava and into the heart. So that's what these two are, superior vena cava, inferior vena cava. Well, if we're talking about measuring the CVP, the central venous pressure, the pressure in the veins closest to the heart, or centrally, what we are talking about is measuring a pressure as close as we can to this area, right? This is the cavo-atrial junction, all right? The cavo-atrial junction. And why do we call it that? Well, it's just based on the names, right? So this is the superior vena cava, SVC, oh, let us meet our computer. And this is the right atrium. So the cavo-atrial junction is where the superior vena cava meets the right atrium, or cavo-atrial. And that gives us this marker for the filling pressure of the right side of the heart, all right? Or the filling pressure, the pressure on the cavo-atrial junction. And let's talk about what that means. Let's elucidate that, tease it out a little bit. The filling pressure on the right side of the heart. Well, pressure is exactly what it sounds like. It's a measurement that you can take using a catheter and a transducer. And that pressure measurement of the right side of the heart is the pressure at this cavo-atrial junction. So what you essentially do is you have to have a way, an invasive line that sits right at this cavo-atrial junction that you can transduce a pressure. And that pressure is then a surrogate for your right atrial pressure, because this is your right atrium right here. So if you have a catheter sitting in the cavo-atrial junction right here, and you measure a pressure at the end of that catheter at the cavo-atrial junction, that's going to be a surrogate for the right atrial pressure. And that can be important for a number of reasons. It helps give us an idea of fluid status. It can help give us an idea of cardiac function because obviously this is blood filling pipes and chambers. That's what it is. And if you have a lot of blood in a pipe, you're going to have a higher pressure in that pipe. If you have just a little bit of blood in that pipe, you're going to have a lower pressure in that pipe. The plot's a lot thicker than that, but it is a simple way to kind of get a foundational understanding of what exactly this is. So the central venous pressure is at the cavo-atrial junction, right? Cava being superior vena cava, atria being right atria, and the junction of the two. And it's a surrogate for the right atrial pressure, or the filling pressure of the right side of the heart, aka the pressure in this area when blood is flowing into the heart. All right? The measurement of it requires what we call a central venous catheter, or a pulmonary artery catheter, PAC. We won't dive into that too much, but a central venous catheter. And that is a central line, if anyone has heard of that. Those that haven't, it's essentially a long IV that you put in, typically at the neck, and you kind of put it all the way down and try to get it to end right at this cavo-atrial junction. So if we were to do just another kind of side drawing over here, you have a head. This is a patient's neck, going down to their shoulders and their heart, kind of sitting right here. Whoop. And then this is their internal jugular vein. This is their subclavian vein. And they're all kind of stringing together into the SVC. All right, so this is the internal jugular vein. This is the subclavian vein. And you can access either of these to put in a central line. You essentially poke in the skin at the neck, or poke in the skin kind of by the clavicle. You put a needle in, then you string a guide wire in, and then you put a catheter over the guide wire. So the catheter kind of sits at the outside of the neck, all right? And then the catheter goes in through the internal jugular vein to the SVC, and you try to get the end of the catheter to sit right at that cavo-atrial junction, or it goes into the subclavian vein into the SVC, right? And since the catheter is sitting right at that cavo-atrial junction, like we talked about, you can transduce a pressure off that catheter to see what this right atrial pressure is. But you need a central line, and you can put central lines in the femoral veins as well, which are the veins in the groin. But that doesn't go to that cavo-atrial junction. So getting a CVP off a femoral central line is, pretty much useless. There isn't a real reason to do it. It has to be a central line in either the internal jugular vein or the subclavian vein. And you want the end of that catheter to be as close to the cavo-atrial junction as possible. Sometimes you'll put in these central lines, and the end of the catheter will sit way up here in the superior vena cava, not at this junction, and that measurement's going to be less accurate, right? Because it's farther away from the right atrium. All right, so you have this catheter in. Now you want to measure a central venous pressure. Well, essentially what you're doing is you're just transducing a pressure off this catheter tip. But to do that, you have to make sure you zero the catheter, and this is really important. So what you typically will do is you'll have the patient lay flat, supine, flat on their back. And you'll have to zero the catheter at what we call the phlebistatic axis, which is around the fourth intercostal space. So down here we have a human drawn, laying on their back. Here's an eyeball for them, right? Here's their mouth, nose, ear, is their chest. And the fourth intercostal space is going to be the fourth space, the space between the ribs, right? So ribs 4 and 5. So you can count ribs, if you were to count 1 rib, 2 ribs, 3 ribs, 4 ribs, 5 ribs. Then you'd have your fourth intercostal space here. And the reason that they say measure this at the fourth intercostal space is because that is about the area where the right atrium is in the body. Because what you want to do is you want to zero this pressure at the right atrium, because let's say you were to zero it lower. It was, so you want the pressure to be zeroed right at the phlebistatic axis, right around here. All right. If you zeroed it too low, then the body or the measurement would give you excess of this much, right? If you zeroed it too high, way up here, then the measurement would give you excess of this much. So it'd be inaccurate. You want the zero read to be right at the cavo-atrial junction because that's zero. That is where the pressure that you want is the origin of the pressure that you want right at that cavo-atrial junction. All right, where if you zero it too high or too low, you'll get wildly inaccurate numbers. So you have to zero it at that phlebistatic axis, which is right around the fourth intercostal space, mid-axillary line, axilla being armpit, so kind of in this mid-axillary line. Because if you lay it on your back and you're looking at someone's side, that's about where their heart should lie. And you'll get inaccurate measurements if it's too high or too low, if the zero is too high or too low. Okay, so now you have a central line in the subclavian vein or internal jugular vein. You have the end of that central line sitting right at the cavoatrial junction. You've laid the patient flat. You've zeroed the central venous pressure right at this phlebistatic axis, the fourth intercostal space, right where that right atrium is sitting. And now you actually get a measurement. Well, what are normal values? It's a pressure. So it's measured in millimeters of mercury, just like any other pressure. But we wrote a number of different values here because you'll see all sorts of ranges for what a normal central venous pressure is. You'll see some resources will say 0 to 6, some will say 8 to 12, and it depends a little bit on what you're looking for what the normal is. I know that sounds a little counterintuitive because a normal should just be a normal, but everyone's different, right? Young, old, obese, normal size, normal heart, abnormal heart. So in our opinion, normal CVP is anywhere between 4 to 8 millimeters of mercury. That tends to be about what we go with. So let's just say the CVP is too high. So CVP is high. Let's say the CVP we measured, you got a good measurement. It was zeroed right at that phlebistatic axis and the CVP came back at 18 millimeters of mercury. Well, if we think about what that means that pressure at the cavoatrial junction is very high. And if we think about what you're measuring blood in blood vessels and heart. So that can mean that you are hypervolemic. You have too much volume in your blood vessels and it's leading to a high CVP. Now, there's a lot of challenges with using CVP measurements this way because it is measuring a pressure. It's not measuring fluid. It's just measuring the pressure in the area that the central line is sitting. And it can be a surrogate for volume status, but it's not perfect, right? Because other things you could picture affect it too. So if you're measuring a pressure right in this area, that's what we said, we're measuring a pressure right here. Well, what if you had really bad tricuspid valve regurgitation? Blood should be flowing in one direction, right? The atria contracts, blood goes through the tricuspid valve into the right ventricle, the ventricle contracts, and blood goes up the pulmonary vascular system into the lungs. But if you have tricuspid valve regurgitation, some of this blood is actually getting regurgitated back into the right atrium and is shooting up towards that central line. And that will cause this pressure, the CVP, to be high, and has nothing to do with fluid, right? It just has to do with the fact that you have tricuspid regurgitation. Let's say you have a dilated right atrium that isn't able to squeeze that well. That'll cause your CVP to be higher because that pressure will seem higher because the right atrium can't squeeze all that blood out as robustly as someone else. So there are different things that affect the CVP, and it's things we'll talk about in future videos. But a lot of people traditionally use CVP measurements as like this equivalent for volume status, and it's not perfect. It gives you an idea, but it's not perfect. So on the other hand, let's say your CVP is really low. Your CVP is just 1 millimeter of mercury. Well, that means the pressure at that cavoatrial junction is very low. And if we're going with the surrogate for volume status, that could mean you're hypovolemic, dehydrated, hypovolemic, and that you might need fluid resuscitation. Compared to that high CVP, that can mean you're hypervolemic. And we'll do a more advanced discussion on this in future videos, but we just wanted to give that introductory sense today. Today, central venous pressure tracings or waveform basics. We're going to decipher the mystery of the CVP waveform, what the different parts of the waveform mean, how they correlate to the cardiac cycle, how to interpret abnormalities, etc., etc. If you're interested, we have our Patreon page linked in the video description. On our Patreon page, we do put some outlines for the different videos. Here's the CVP tracings. So if you had an interest and want to join the Patreon page, you would have access to kind of follow along with these outlines while learning the video. All right, no further ado, central venous pressure tracing waveform basics. So Central venous pressure we talked about in a previous video. We'll link it in this video's description. It's the introduction to CVP. So definitely check that video out because it kind of lays the foundation for understanding this video. But in that video, we talked about how central venous pressure, CVP, is a surrogate for the right atrial pressure. And we talked about how to get a CVP measurement. You need a central venous catheter that sits right at this cavo-atrial junction. This is the superior vena cava. This is the right atrium. We'll just finish the diagram. Right ventricle, left atrium, left ventricle. This is tricuspid valve. This is pulmonic valve. This is the pulmonary system. This is the aortic system. This is the IVC, inferior vena cava. But we talked about how a CVP measurement is right at this cavo-atrial junction where the superior vena cava intersects with the right atrium, cavo-atrial junction, cava atria. And to get that measurement, we talked about how you really need a central line in either the internal jugular vein or the subclavian vein. We also mentioned how you can get it off a pulmonary artery catheter as well. And we will just sketch it quick, right? If you have a human here, this human's got a long torso, here's their head. We talked about how they have their heart here, and we want to measure a pressure right at this cavo-atrial junction, and to do that, you have to have a central line going in to the superior vena cava, right? That's what we said dumps into that right atrium, the superior vena cava. To get into that superior vena cava, though, which we'll say is measured, represented here, you need to either access it through the internal jugular vein, or there's another vein called the subclavian vein. And if we were to zoom in on a person's head, we'll say here's their head, all right, here's their neck. We drew a long neck just for the sake of the drawing. Here's their shoulders. Again, we'll say their heart's right here. The internal jugular vein travels through the neck and then dumps into the superior vena cava. The subclavian vein travels through the chest and dumps into the superior vena cava. So that's internal jugular, that's subclavian. And you could put a central line, either poke into the neck and string it all the way down to the cavo-atrial junction, or you could poke into the chest wall and string it down to the cavo-atrial junction. So you need a central line in either the internal jugular vein or the subclavian vein, a femoral central line. Femoral vein is veins that run through the groin, so you could put central lines in as well. Will not give you a CVP measurement that's worthwhile. You can certainly get a pressure off a femoral central line, a central venous pressure, but it won't be an accurate cavo-atrial pressure that you can use. So one of the benefits of CVP is the waveform tracing, because it can tell you about what might be going on. But to do that, you have to understand what a normal central venous pressure tracing is. Now remember, we said that this catheter that we're measuring the CVP off of sits right at that cavo-atrial junction, or where the superior vena cava meets the right atria. And the pressure that it is experiencing is going to be a product of the cardiac cycle. And this red line, red here, is going to be the CVP tracing, or CVP waveform. Whereas the green line is actually the electrical cardiac telemetry tracing, right? So I want you to just focus on the red line for now. In the red line, we have 5 different parts, right? We have the A, C, X, V, and Y components of the CVP tracing. This is one CVP cardiac cycle. All right, ACXVY. And if you can picture that central line measuring the pressure right at that cavo-atrial junction, and then we're going to start a cardiac cycle. And the CVP goes skyrocket high into the A wave. And the A wave is right atrial contraction. If you need help picturing it, we're going to scroll back up. This is where we're measuring the pressure, right at the cavo-atrial junction. So when the right atria squeezes, all right, that's going to increase the pressure in the right atrium, which is going to increase the CVP. Now what happens is you get that peak, and then you start to descend until you get this little blip, this little increase again, this C wave. And the C wave is early systole with the tricuspid valve bulging into the right atrium. So if you need to picture that, so the right atrium finished squeezing. Maybe we'll erase some of this to make it easier to visualize with less scribbles. So we said the first wave is that A goes up, comes down into this little increased blip, right? So that's A. A is right atrial contraction. This blip here, though, is the right atria is done contracting. All the blood's flown into the right ventricle. The tricuspid valve has closed. This is the tricuspid valve. It's closed now. And then the right ventricle contracts. And the right ventricle contracts and shoots blood through the pulmonic vein into the lungs. But when that right ventricle contracts, even though this tricuspid valve is closed, it's still going to push on the closed tricuspid valve. And it causes that valve to just kind of bulge up a little bit, right? Just bulge up a little bit into the right atrium. And that little bulge up in the right atrium increases this right atrial pressure just a touch, which causes this blip up on the CVP. That's the C wave, all right? So you can see C here. So you can picture that, right? A wave, this is the right atria contracting. Right atria is done contracting. It starts to relax, right? So that's right atria contracting. This is the right atria relaxing. The pressure starts to go down. This is that tricuspid valve bulging, is the C wave, and then it keeps relaxing, right? That's the X, mid-systole, when the right atrium continues to relax. Because after this valve's closed and all the blood's pumped into the right ventricle, the tricuspid valve bulged upwards as the right ventricle is contracting. The right atrium is actually expanding outward. It's relaxing. And since the CVP measurement's right here, as this right atria relaxes, you're going to get this kind of whole down slope. That's the X descent, is the right atria contracting. Relaxing. So then you get to this trough. And this trough then goes into the V wave because the right atrium's empty of blood now. We have the right atrium that originally contracted, all right? Then the right atrium was done contracting and it started to relax. As the right atrium's relaxing, the right ventricle contracts, and that pushes the tricuspid valve into the right atria, causing the C wave. But the right atrium still is relaxing, so the X descent is as the right atrium continues to relax. But now the V wave is the right atrium starts to fill with blood again. All right, so late systole with rapid filling of blood into the right atrium. That's the V wave. And then the Y wave is early ventricular filling. It's early diastole with early ventricular filling. That valve started to open up. The right ventricle is starting to fill with blood. And then it's right before the atrium then contracts again. And that goes back into the A wave. All right, I know it sounds confusing, but if you just picture the cardiac cycle, it should all start to kind of add together. So I'm going to see if I can erase all of my drawings here, and that way we can go through it without all the scribbles. So if we start and we picture that central venous catheter sitting right at the cavoatrial junction, and then we start a cardiac cycle. The A wave is when the right atrium starts to contract, and it increases pressure right at that cavoatrial junction. Now, the atrium's done contracting. It starts to relax, so the pressure goes down. As it's relaxing, the right ventricle contracts, and it bulges the tricuspid valve into the right atrium, causing the C wave. Once that's done, the X descent is just the rest of the right atrium contracting. Right atrium is, relaxing. Right atrium is now relaxed and empty. It starts to fill with blood, right? That's the V wave. The right atrium is filling with blood. Then Y is when that valve opens and some blood starts to go into the right ventricle. And then A again when the right atrium contracts, right atrium relaxing, tricuspid valve bulges into right atrium as right ventricle contracts, but right atrium keeps relaxing. Now blood starts flowing into the right atrium, then blood starts to empty out into the ventricle, and again it starts again. If we look at the telemetry strip, this might be more confusing. If you're not quite there yet, that's okay, but for those of you that are still with me, this is telemetry. So this is a P wave. P wave is an atrial contraction, and we have a whole EKG series linked in the video description. This is the QRS complex, and this is ventricular contraction. Okay, so P is atrial contraction. It lines up, right? This is right atrium is contracting. Then right atrium relaxes. QRS is when the ventricle contracts, bulges that tricuspid valve into the C wave. All right, atrium still relaxing. This is a T wave, that's ventricular relaxation. So that's when the atrium's still filling with blood. Again, opens, A wave starts again. So that is a normal CVP tracing. Definitely let us know what thoughts, questions, comments you have down below. It certainly is confusing. On our Patreon page, we'll post some practice questions intermittently, and we can all talk about them together as well. And we're going to go into some abnormal CVP tracings too in future videos, so definitely check those out. We'll link them in this video's description once they come out. Quick intro in that regard. Central venous pressure is often looked at as a surrogate for right atrial pressure. Or the filling pressure of the right side of the heart, things we dove into in those previous videos. It's a pressure that's usually measured at the cavo-atrial junction, right? So right around here, this is the right atrium, this is the superior vena cava. You put a central line in the internal jugular or subclavian vein. The tip sits right at this cavo-atrial junction, and you measure the pressure right in this area. Again, things we talked about in those previous videos. As such, you need an internal jugular central line, a subclavian central line, or a pulmonary artery catheter to get these measurements. Again, talked about in those previous videos. A femoral central line, which is a central line in one of the veins of the groin, will not give you accurate pressures. Then when you zero at the phlebostatic axis, talked about in the previous videos, and transduce a waveform, this is what you will often get. This is a normal CVP waveform. And we talked about this in our last video, linked in this video description, the 5 different components of a normal CVP waveform. And these 5 components are based on the pressure that catheter right at that cavo-atrial junction will see during the cardiac cycle. And it starts with atrial contraction. That's this A wave. The right atrium contracts. So when it contracts, if we think about the heart, the right atrium contracting in is going to increase the pressure in the right atrium and increase the pressure that catheter is seeing. Then the right atrium starts to relax and the right ventricle contracts. When the right ventricle contracts, it's going to push that tricuspid valve upwards. That tricuspid valve is going to bulge into the right atrium, and that's this C wave here, is that tricuspid valve bulging into the right atrium. But the right atrium continues to relax, and that's the X descent, right atrium relaxation. Once that right atrium is totally relaxed, the V wave is when the blood starts to refill the right atrium. All right, the blood fills the right atrium, then it starts to empty into the right ventricle, and then you get right atrial contraction again. All right, and that gives you your ACXVY wave, and that's what we talked about in those previous videos, so definitely check those out if that is not familiar to you. But today we want to talk about Canon A waves. So this is something you might see if you're looking at the monitor, the CVP tracing of a patient. And it can help you if you recognize this in identifying pathology going on, right? Because these Canon A waves are pathologic. They call them Canon A waves because they're these humongous waves that you'll see on the CVP tracing. For instance, this is the normal single kind of heartbeat CVP tracing, and the A wave is usually the highest, right? This is right atria contraction. But these Canon A waves go much, much higher. These are all Canon A waves right here. And you can see there's these huge cannons of waves that launch up. So what might cause that? If you think about what that means, that is an A wave. So that's right atrium contraction. But what would cause it to go so high? Well, that means the right atrial pressure has gone sky high when the right atrium is trying to contract. And what could cause that is if the right atrium is contracting against a closed tricuspid valve, right? If we draw what is going to be not as good of a drawing of the heart, we have the right atrium here, we have the right ventricle down here, and the right atrium empties through the tricuspid valve into the right ventricle. But if this tricuspid valve never opens and the right atrium contracts and causes a huge increase in right atrial pressure without that valve opening, that will cause this Canon A wave. So it's when the atria contracts against a closed tricuspid valve, causing significant backflow, leading to the central venous catheter that's sitting right at that cavo-atrial junction, right, in the superior vena cava. It causes that catheter measuring the pressure right here to see this huge increase in pressure. Well, what could cause that? Because that's kind of funky, right? When the right atrium contracts, the tricuspid valve should open. That's how it works. Well, what can cause that is when there's dissociation, when the right ventricle is trying to contract at the same time as the right atrium, because that's going to increase the pressure in the right ventricle even more, because the right ventricle is stronger. And if the pressure is increased even more in the right ventricle and the right atria contracts, the tricuspid valve will stay closed. It won't open because the pressure over here is higher than the pressure here. So if you had AV dissociation, that means that the atria and ventricles are no longer communicating with one another. That means there's some type of heart block or abnormal arrhythmia going on, because usually what should happen is you have a SA node, sinoatrial node here, you have an AV node here, and what typically happens is the SA node sends conduction through the atrium, which then causes the atrium to contract. That pumps blood into the ventricle as this conduction goes through the AV node into the bundle of His, the Purkinje fibers, and that causes then the ventricle contract. So it usually is atrium contracts, then ventricle contracts. But if you have AV dissociation, there's no communication here. Something's gone awry. And the atrium and ventricles are just contracting at random times. And sometimes the atrium will contract first, right? So you have the right atrium contracts against a closed tricuspid valve. It does it again. It contracts again against closed tricuspid valve. And then all of a sudden, it contracts coincidentally at a time where the tricuspid valve opens and you get a normal CVP waveform. But then again, next time it contracts against a closed tricuspid valve, and then it works okay. So there's AV dissociation. The atrium and ventricle are just contracting at random times. And that can be from things like complete heart block. It can be from ventricular tachycardia, when your ventricle is just contracting in this abnormal heart rhythm, and the atrium is just contracting. And again, sometimes that blood might pump through, but sometimes that atrium will pump against the closed tricuspid valve. And if you have a pacemaker and it's not functioning, that can be a cause as well. The key here is that Canon A waves are distinctly different from giant A waves, which we might put in a future video, because giant A waves are when that atrium contracts. We're going to draw it again. The ventricles are small here, apologies. So this is the right atrium, the right ventricle, tricuspid valve. Giant A waves are when the atrium contracts and the tricuspid valve does open, but you still get these giant waves because there might be stenosis of the tricuspid valve, so it's harder to pump blood through, which then increases the pressure that central venous catheter sees. Or it might be because the RV has decreased compliance, so it can't expand as easily. And those are called giant A waves, which are different than Canon A waves. Canon A waves are when the right atrium is pumping against a closed tricuspid valve, not just the stenotic tricuspid valve. Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.